My talk is on update on new drugs in delta hepatitis. Most of delta cases are due to the superinfection of HBV. And if you look at immunohistochemistry, core antigen localization is not cytoplasmic, but it's nuclear, and expectedly, because of the nuclear localization, there is no correlation with liver injury, even in patients who are so-called HBV, HDV codominant cases. So delta hepatitis is a disease of the delta virus, and delta antigen in the liver display correlation, some correlation with ALT and surface antigen levels. I will skip this case, I decided, because we are in Romania and we know delta hepatitis more than some parts of Europe. But I want to mention the diagnosis, and because since we are going to talk on new treatments, we also have to know how to best assess treatment efficacy and how to follow patients. So in terms of diagnosis, we have anti-HDV IgM, IgG, qualitative and quantitative HDV RNA measurements by PCR, immunohistochemistry, delta antigen, quantitative surface antigen levels, and genotype determination. Now, in terms of anti-HDV IgM, these studies clearly shows that anti-HDV IgM titer correlate with ALT here, shown here, and to some extent with histological activity. And semi-quantitative anti-HDV IgM levels appear to also affect prognosis. So the higher anti-HDV IgM levels are, the more the prognosis is worse. But anti-HDV IgM overall is suggestive of acute infection or chronic active infection, but the issue is it's not standardized and HDV RNA is more sensitive. Therefore, anti-HDV IgM may be of use, but for study assessments, it's not enough. Anti-HDV IgG is the first test to be used for searching for HDV. It's not a neutralizing antibody. It depicts only encounter with HDV. HDV RNA testing is necessary to establish active HDV infection. And do not forget, it remains positive for years after successful treatment, including surface antigen clearance. What about HDV RNA? We measure it qualitatively or quantitatively. It's a surrogate marker of treatment efficacy, and until recently there was no standardization, but we now have a WHO standard, and every lab who do HDV RNA measurement should get it. Is this the end of the story? Well, the first international external quality assessment for hepatitis delta virus RNA quantification in plasma has been done, and it is now in press in hepatology. 28 reference labs took part. 13 labs, 46%, made correct measurements. 16 labs, 57%, did not make correct measurements. Of the positive samples, up to 10 samples were found negative by these reference labs, and they all used the HDV RNA standard. So that brings me back to my days at NIH. I spent 2 years at NIH, and I learned a lot, including some notes for new beginners at NIH to give you some information about some questions you don't ask. One of these questions were, if you read manuscripts, let's say basic science manuscripts, you always read samples were handled with care. What does that mean? I learned that it meant they were not dropped on the floor. And if you look at PCR techniques, the technology in terms of commercial PCR technologies have increased dramatically. And you have now PCR technologies where the only thing you have to do is take the samples, took it with your shaking hand, and just spit it to a place within the sample kit. That's the only thing you have to do. You don't have to measure anything. You don't have to pipette anything, and you have the results. You don't do. Everything is done automatically. Now, in that sense, HDV RNA measurements are far away from ideal. To have a standard is good, but it's not the end of the story. Now, in terms of surface antigen level measurements, quantitative surface antigen levels, I think it is important, as I will show in other slides as well. Here, in delta hepatitis, those who have responded also show a decline in surface antigen. I will show you some other examples, but quantitative surface antigen levels is something which should be also in use in assessing delta treatment efficacy. Another issue is genotypes, HDV and HBV genotypes. If you look to Europe, HDV genotype is 1. HBV genotype may differ, D or E, A. In most parts of the world, HDV genotype is 1. But if you look to the Far East, you have 1 and 2 genotypes. And this is important because genotype 2 leads to a milder disease of delta hepatitis compared to genotype 1. So if you do a study in the Far East, you should also check for genotype. And finally, this is more a clinical relevant question. What about assessing delta hepatitis non-invasively without doing a liver biopsy? One thing is to use non-invasive fibrosis scores. And there is one study where we took part which showed that overall, the commonly used non-invasive serum fibrosis marker do not do very well in delta hepatitis. You see area under the curves around 0.6, and this means that they are not much of use. There is another study from the US, from the NIH, which is not impressed now, but will probably be impressed very soon, and they have shown similar results. Our experience in Ankara is more or less the same. We will send an abstract to EASL with FibroScan, and with FibroScan, the area under the curve is much better. Now, in terms of treatment, we know we have interferon treatment. I have to mention interferon treatment because it sets the stage for new new treatments. Now, it's evidence-based, high-dose, long treatment period, but what is meant under long treatment, 1 year maybe, we will discuss it, and sustained virologic response is low. This was the biggest study with pegylated interferon combined with adefovir or alone, and compared with adefovir monotherapy, and more or less 25% sustained virologic response. In this study, interestingly, combination treatment led to a significantly higher decline in surface antigen levels. Therefore, pegylated interferon tenofovir combination treatment was compared in another study with the same centers, more or less, and compared to pegylated interferon placebo. The results were disappointing because, first of all, the treatment duration was not 1 year, but 2 years. Still, there was a quite high relapse rate, and sustained virologic response was not much higher compared to 1 year. Of course, it's not a head-to-head comparison, but the relapse rate, the high relapse rate tells something. And in terms of surface antigen levels, there was absolutely no difference. So overall, there is no progress in delta hepatitis. Why is that so? First of all, progress in HBV did not contribute. Treatment acts, nucleus analog act on HBV DNA polymerase. It's very efficient, but the only function of HBV needed by HDV is surface antigen synthesis, and nucleoside analog do not have an effect on surface antigen synthesis. In delta hepatitis, we have RNA polymerase. It's a cell enzyme and cannot be targeted for treatment. And HDV is considered an orphan disease. It's not endemic, and the potential financial reward is likely to be insufficient for the BMI to invest in the biomedical industry, to invest in delta hepatitis. As you know, we are not living in an ideal world, and that was told us decades ago by Hollywood. Nobody is perfect in this world, including biomedical industry. And in terms of interferon treatment, there's one other thing I want to say. There is, in kinetic studies, it has been shown that there is a long delay before PEG interferon shows an effect. It's like hours in Hep B, in Hep C versus days, 8 hours versus 8 days or so with delta hepatitis. What are the problems with interferon treatment in delta hepatitis? I have listed a few of them, but I'm not going through all of them. Let's start with how can treatment efficacy be best assessed and how consistent and reliable is a sustained virologic response. This is important for new drug development. Best assessment is surface antigen clearance, but this is rarely achieved. Realistic is post-treatment HDV RNA negativity, 6 months post-treatment. How consistent and reliable is that? We know the answer, it's not reliable. What is the optimal duration of treatment? We mentioned 1 year, 2 years, there is no difference, so 1 year is enough. We did a study, what we did, we looked at our database and looked for treatment durations in our database, in our patients who received interferon treatment and who had a good follow-up. There were 99 patients who received at least 6 months of interferon treatment. Of these 99 patients, 16 had a maintained virologic response. Now, for maintained virologic response, we used at least 2 years of HDV RNA negativity after treatment discontinuation, not 6 months. 16 patients did not have a maintained virologic response. They did not receive further treatment. So we were left with 67 patients who received up to 2 years of treatment. Again, 6 had a maintained virologic response, 20 did not and did not receive further treatment. And so it continued until we had 8 patients who received a total, not constantly, a total of more than 5 years of treatment. And out of these 8 patients, 4 had a maintained virologic response, 4 did not. And overall, the cumulative probability of maintained virologic response in these patients was increased with extended treatment duration. In patients who received 5 years or more, in patients who received 3 years or more, it reached 50%. Of course, this is an overestimation because you have to consider that patients who respond somehow will be more likely, will be motivated to receive another course of treatment, whereas those who have no response whatsoever will not be motivated to receive further treatment. But in terms of interferon responder versus non-responders, patients who had low GGT and patients who had high platelets and patients who had low surface antigens were more likely to be responders to treatment. And patients who had a maintained virologic response in terms of cumulative probability of liver transplantation or mortality, patients who had a maintained virologic response, as you can see on the red line, were less likely to have these outcomes, mortality or liver transplantation. So overall, having a maintained virologic response affected beneficially the natural course of disease. In terms of clinical event, whether it's hepatocellular carcinoma development, decompensation, mortality, liver transplantation, if we compared those patients who had a clinical event versus those who did not have a clinical event, patients who with high platelet counts and patients who did not have cirrhosis and patients who responded to treatment did not have a clinical event, were less likely to develop a clinical event. And by multivariate analysis, cirrhosis at baseline and not responding to interferon were associated with developing a clinical event. Just to give you an example of cirrhosis versus chronic hepatitis, as you can see, development of a clinical event was much more often seen with cirrhotic patients compared to non-cirrhotic patients. But patients who had a maintained virologic response also on long-term follow-up were more likely to have clear surface antigen. 38% of patients who had a maintained virologic response had cleared surface antigen on the long run. And low surface antigen levels at baseline and response to interferon treatment was associated with surface antigen clearance by multivariate analysis, responder to interferon treatment. Response to interferon was the only independent predictor of surface antigen clearance. Finally, and this is, I think, important in terms of new drug development, and that is, can response to treatment be predicted, or better, can non-response be predicted? Month 6 HDV RNA negativity appeared to predict response in the past studies, and this was confirmed in the sub-analysis of the HEDIT-1 study. As you can see, patients who were negative, who had HDV RNA negativity at month 6, had also a response post-treatment. But more importantly, we want to see what is the predictor of non-response. And non-response cannot be seen as non-response at end of treatment, because patients who had at post-treatment month 6, half of them had at end of treatment were HDV RNA positive in the HEDIT-1 study. So therefore, being HDV RNA positive at end of treatment is not equal to not responding to treatment. What we arbitrarily choose as non-response to treatment was a less than 1 log decline of HDV RNA after 1 year of treatment. And for this, again, HDV RNA at week 24, less than 1 log decline of HDV RNA at week 24 appeared to predict this so-called non-response. Now, new treatment. What are the new targets for HDV treatment? One is at the beginning of at the entry level, we have here entry inhibitors, and you may consider toll-like receptor agonists, which were the innate immune response started to be triggered as also at the beginning of this HDV life cycle as targets for delta hepatitis treatment. Another target is Preenlation inhibitors. The nucleoprotein complex, the newly formed nucleoprotein complex in the nucleus goes out of the nucleus in the cytoplasm. It has to be covered by surface antigen to finish viriomorphogenesis. And since the nucleoprotein complex is hydrophilic, so lipophobic, this attachment is difficult, and addition of a prenyl group, a 15-carbon prenyl group, makes the nucleoprotein complex lipophilic, and the attachment is finished. So Preenlation inhibitors in case of delta hepatitis, farnesyl transferase inhibitors inhibit this step. And then we have nucleic acid polymers. The mode of action is actually not very well known, but probably they affect the extrusion of the virion out of the cell. Now, effect of the hepatocyte entry inhibitor mercuridex in delta hepatitis. 8 patients were administered mercuridex for 6 months daily. 8 patients received in combination with pegylated interferon the same regimen, and these were given as subcutaneous injections. The comparison of IV mircludex versus subcutaneous injections showed that subcutaneous injections had 85% bioavailability. And in this study, remember 1 log decline, 6 of 7 patients experienced HDVR decline of more than 1 log at week 24 during mircludex monotherapy. And in terms of combination treatment, 7 out of 7 had this decline. HDVR RNA became negative in two patients during mircludex monotherapy, but these were patients who had low levels of HDVR RNA to start with. Now, the primary endpoint of this trial was a reduction of surface antigen of more than 0.5 logs, as I said, of surface antigen. And this was not achieved in any of the patients whether monotherapy or combination therapy. So the study showed some benefit, but not at the level the researchers were expecting. I just want to mention that heparan sulfate glycoproteins act as co-receptors for HBV and delta entry into the hepatocyte in addition to the main receptor NTCP. And here glypican 5 is the protein is important, and maybe combination treatment could be considered also with this in this context. Now, Preenlation inhibitor lonafarnib is the farnesyl transferase inhibitor which has been used in delta hepatitis. A phase 2 proof of concept study for 4 weeks showed that it led to a dose-dependent decrease of HDV RNA. Additional studies for optimization of the use of lonafarnib were performed. These were done at my center in Ankara, and what we have seen is that first of all, with lonafarnib 200 milligram BID dosing, we had the same amount of decline of HDV RNA as with the NIH data. But in terms of higher dosing, it was associated with side effects. Lonafarnib 100 milligrams with ritonavir boosting and lonafarnib in combination with pegylated interferon appeared to be better treatment modalities than monotherapies. And the reason for that is the issue of side effects. We tried to find a dosing regimen which combines efficacy with tolerability. And if you look at 200 milligrams BID, 300 milligrams BID, and the degree of side effects according to CTCAE criteria, you can see with lonafarnib ritonavir combination, side effects were at the level of grade 1, whereas with the others, there were many side effects of grade 2. What are the side effects? Basically, GI side effects, nausea, diarrhea, and weight loss, and anorexia. This is important because it has been shown, and we also have shown that, this is the NIH data, serum concentrations of lonafarnib have a very nice correlation with viral load reduction, and side effects may prevent optimal serum concentrations. In terms of lonafarnib's ritonavir combination, this is 100 milligram lonafarnib concentration, and by boosting 100 milligram, you increase the lonafarnib serum concentrations by up to 5 times, and without losing tolerability. Therefore, lonafarnib ritonavir boosting may be the right way to go, and we have to find the best combination. There are more data, but I cannot show them, but they will be presented at the ASLD. There will be many presentations of lonafarnib and monotherapy or in combination with ritonavir and so on by different centers. Another approach is small interfering RNA. This was shown at ASLE 2014. There was a dose-dependent decrease of surface antigen by a single injection of ARC520. There will be other studies, hopefully, with repeated doses, but we have to wait and see. Now, nucleic acid polymers for treating HBV. These are oligonucleotides, and their action is not dependent on their oligonucleotide structure per se, but on the polymer chemistry of the oligonucleotide. They bind with high affinity to amphipathic protein structure, and these amphipathic protein structures supposedly are very rare in normal human biology, but are observed in the virus. And they were used in delta hepatitis, in hepatitis B. Now look at the results. If these results are correct, we have a revolution in hepatitis B treatment. Forget about delta, but also for hepatitis B. Look here, surface antigen levels. You have after just 3 months, 10 or 12 weeks of nucleic acid polymer treatment, you have a reduction of surface antigen levels at the level of 4 logs. This is unbelievable. Now, these studies have been performed in Bangladesh 3 years ago, 4 years ago. The problem is it has never been published. Similar data have been now generated also from Moldova, and they say, when asked to them, those patients who had negative, who developed surface antigen negativity with 12 weeks of treatment, remain negative. But the question is, if you have that super result, why don't you publish that? We have to wait and see. HDV RNA, similarly, very robust decline. So nucleic acid polymers are something we have to follow. Summary and conclusion: the only effective treatment in delta hepatitis is with interferons. Treatment beyond 1 year needed in a sizable proportion of patients. Post-treatment week 24 is not equal to SVR in delta hepatitis. HDV RNA standard now available, but it's not the end of the story. As I said, the future, there's now hope, all these approaches, so please stay tuned. Thank you.